Dr. Bamshad is a diplomat of American Board of Physical Medicine and Rehab. He's presently on staff at the Cedars-Sinai Hospital and is medical director for Precision Occupational Medical Group, which oversees 9 physicians, 23 locations spanning throughout Southern California and Las Vegas. Let's give a hand for Dr. Bamshad.
Can you guys hear me okay? Yep. Okay, great. I'm Sean Bamshad. I've been doing nerve testing for about 10 years now. Today I'm going to talk to you guys about just some of the basic concepts of electrodiagnostics. Try to kind of maybe answer some of the basic simple principles of electrodiagnostics, which basically is made up of 2 main components, which is the nerve conduction studies and electromyography. This is your basic electrodiagnostics machine. This is the basic setup when you guys refer a patient to us to do nerve testing. This is basically their experience is within the examining room on a examining bed with the machine next to them and the practitioner doing the test. And they always have a really nice time. The basic purpose of electrodiagnostics, and later on towards the end of the talk, I'm going to talk a little bit more about pertinent things as in regards to what are appropriate nerve testings that you guys come across as far as authorizing or questioning whether it should be done or whatnot. I'll get a little bit more into that later as well. But the basic purpose of electrodiagnostics is either to confirm a tentative clinical diagnosis. For example, carpal tunnel is your basic diagnosis that we see quite often. And it's really not carpal tunnel until you do electrodiagnostics and you truly see a delay in the median nerve or a loss of nerve size. And so the nerve testing really rules in the tentative clinical diagnosis of carpal tunnel. Sometimes you want to exclude other disorders. For example, you want to do shoulder surgery for an impingement syndrome, but you want to make sure that there isn't a C5 radiculopathy that might mimic pain at the shoulder area. So this will help exclude some other disorders. And other times you want to characterize a disease. Location, for example, is it a L4 radiculopathy versus an L5 radiculopathy? Sometimes the severity and progression, for example, in entrapment neuropathies, like a cubital tunnel or a carpal tunnel, we can see how delayed the nerve is or how much loss in size there is in the nerve. So let's start with nerve conduction studies. This is your basic stimulator probe that we use to stimulate the nerve. And as you can see, the electrodes are attached. The nerve is stimulated. They get different level sizes of electrical stimulations, which can be a little bit uncomfortable at times. And when you stimulate the nerve, you get a curve like this, which allows us to analyze how the nerve is functioning. And I use the word function because in nerve conduction studies, what we're doing is we're examining the function of the nerve. And for all practical purposes, there are some other things, but for the most part, we're looking at the speed and the size of the nerve to evaluate its function. With nerve conduction studies, we're dealing with neuropathies, and in our setting, as far as workers' comp goes, the entrapment neuropathies are by far the predominant neuropathies that we'll be dealing with, which include the carpal tunnel, which is entrapment at the wrist, cubital tunnel, which is ulnar entrapment at the elbow, Guyon's canal, which is ulnar entrapment at the wrist, fibular head, which is peroneal entrapment at the knee, and tarsal tunnel, which is tibial nerve entrapment at the ankle. So these are by far the types of entrapment neuropathies we'll see in our setting. carpal tunnel by far being the most common. Other neuropathies, which we don't really deal with as much, would include peripheral polyneuropathies, Guillain-Barré, Charcot-Marie-Tooth, congenital neuropathies, other familial polyneuropathies and whatnot. So when we talk about the intrapid neuropathies, which again pertains to us, what are we talking about? We're basically talking about chronic inflammation within a confined space. And what I mean by that is, for example, in carpal tunnel, you get the repetitive use, overuse syndrome with the chronic inflammation at the wrist, the tendons, the ligaments. This chronic inflammation causes not only a buildup of swelling, but also buildup of scar tissue. And when I say confined space, I basically am talking about where the nerve is running. You have your carpal or wrist bones, you have your carpal ligament, or what's called the flexor retinaculum, that covers it through the top, and you got this confined space where all the tendons are running through and the median nerve. Well, with chronic inflammation, you're going to get a buildup here of swelling, scar tissue, and basically pressure buildup. Let's see what I do here. Let me get rid of this. So basically, you get this chronic inflammation within the confined space, pressure buildup, and ultimately, we get the nerve compression. Hence, we call it median neuropathy across the wrist, or median nerve entrapment across the wrist, or carpal tunnel syndrome. So when we talk about carpal tunnel syndrome, being that it's the most common of the entrapment neuropathies, I wanted to show you some examples of, as practitioners, when we do electrodiagnostics, what are we seeing? How are we diagnosing it when we report to you guys that there's carpal tunnel? Well, when we do nerve testing, these are the kind of waves we see. And this is the right median nerve sensory component. There's sensory, there's motor components. We're just going to, for just keeping it somewhat basic, we're just going to look at the right median nerve sensory here. This is a normal nerve. Oops, I did it again. I'm not sure if you guys can see what I'm pointing at down here, but basically we'll look at the speed, which is 3.1 milliseconds, and that's a normal speed. For the normal population, we generally speaking want it to come before 3.6 milliseconds, and the size is 49 microvolts, which for the general population we want it to be above 10 to 15 microvolts. So this is a very normal looking median sensory nerve. Well, what happens in a carpal tunnel? In a mild carpal tunnel, if you look at the curve here, when I go to the next slide, do you see how it just kind of moves over just a little bit? It moved over because it's coming in just a little bit later. Here it comes in at 3.1 milliseconds. Here it's coming in at 3.9 milliseconds, which is beyond our normal range of 3.6 milliseconds. And this little slight delay in the nerve is showing us that there is some kind of a delay going on, which we would call it a mild carpal tunnel because the size is still pretty maintained. And so you're not losing nerve size, it's just being delayed in its progression. So that was a mild. So when do we see a more of a severe carpal tunnel? Is when this is what happens to the nerve. So we had this moved a little bit to the right and delayed, and now it's quite delayed, and there's a lot of loss in the size of the nerve. And so this is the type of stuff we're seeing when we are doing electrodiagnostics and calling things carpal tunnel, severe, axonal loss, that sort of type of thing. And we'll talk about some of those terminologies at the end as well. But this is a basic scenario of nerve testing that we do. Now, we don't just do the median sensory to rule in or rule out carpal tunnel. We're going to have to do the ulnar nerve, the radial nerve, the median motor, the F waves, whatnot, because the only way we can rule in a carpal tunnel is by showing that the other nerves are functioning fine. And we'll review that when we do an example of a case. Electromyography is basically taking a monopolar needle and we're actually inserting it into many muscle tissues, and the needle will pick up the electrical activity of the nerve. This is an example of a monopolar needle that we actually do stick into the muscle tissue. So it is a somewhat of a painful test. So sometimes when patients refuse the test, I mean, there is good reason. It's understandable. This is an example of us taking a needle and jabbing it in there and probing and all that kind of stuff. Not necessarily fun. So what happens when we do the EMGs is now we're looking at the electrical activity of the nerve muscle. So instead of function, we're looking at the activity now, which is this is a kind of a waves we'll see. So basically what are we doing with electromyography is instead of function, we're looking at the electrical signal of a motor unit. This is the nerve, this is the motor unit. At rest, the motor unit is electrically silent. And this is important because this is what we're testing, is we're looking for silence at rest during the EMG. So when we're inserting the needle in the muscle tissue and we're asking the patient to relax the muscles, we basically are listening for silence. There is some normal basic kind of an apple crisp muscle sound when we stick the needle in, but once we let go of the needle, it should be electrically silent. So what happens with axonal injury? And axonal injury is the other component of quite popular things that we see in workers' comp, which are the radiculopathies or the pinched nerves of the neck and the back. When there is injury to the motor axon, and an example of that is our radiculopathy or the herniated disc. This is basically a normal disc. This is your disc. This is your vertebral body. You got your spinous process. You got your transverse process. These are the nerve roots here, which come out. This is where the spinal cord runs, and this is a normal spinal canal. Here is a herniated disc, and as you can see, it's compressing the nerve root. And when it's compressing the nerve root, you get axonal injury. Axons are sheaths around the nerve that serve as protectors and allow for normal progression of the nerve stimulus. When you get axonal injury, you get membrane instability. Membrane instability is when you get your sodium chloride channels unstable, and at rest they start sending signals which they're not supposed to be. Once at rest they start sending signals that are abnormal, we get what are called spontaneous depolarizations from the muscle fibers. This is at rest, which again we said at rest the muscle should be electrically silent, but now it's not silent because of the axonal injury, and we get phenomena such as what we call positive sharp waves and fibrillation potentials. This would be a normal motor unit when the person is activating their muscle, and at rest it should be completely silent. This will be a complete flat line. But once at rest we start seeing positive sharp waves like this and fibrillations like this, we know that there's some kind of an axonal injury. There's some denervation potentials going on. And as I mentioned, in what's pertinent to us, by far most common are the radiculopathies, which are the pinched nerves at the cervical and the lumbar levels. Sometimes we'll come across plexopathies, and then other things that we'll see with electromyographies are motor neuron diseases, myopathies, advanced neuropathies, which are much less pertinent in the workers' comp world. This is by far the most common. So this we already talked about. There is one big limitation of electromyography that I do want to mention is that we talk about axonal injury. We can only test motor axonal injury. When in reports you might see a normal test and then the practitioner gives you a little caveat of saying, well, we cannot test sensory roots. They're basically saying that we cannot test the small sensory fiber that's coming out of the spine that might be inflamed from a bulge or an annual tear or something, and giving the patient some pain and numbness and whatnot. And there's always reasons where they might have some pain and numbness that we can't pick up on. But those are much more minor injuries because it's just a little inflammation of the sensory root as opposed to an actual axonal injury. So that's electrodiagnostics, nerve conduction studies, and electromyographies in general. Let's do a couple of case examples, and I think this will shed a little bit more light of how it is that we put the picture together. So in case one, 46-year-old right-handed female, administrative assistant for 15 years. She presents with a gradual onset of right hand numbness, started initially at nighttime, but then starts having it during the day. There is some associated intermittent pain at the wrist and hand. Symptoms developed over the past year or so. There's no associated trauma. There's no neck pain. She's recently noticed that she's dropping things. Her medical history is only significant for asthma. She's not a smoker. She's been using a wrist brace at night, which gives her some help. She's taking some NSAIDs, anti-inflammatories, which seems to help the pain, but not really the tingling. So this is very typical case we get, and it sounds very much like a carpal tunnel. So what do we see in a patient like this when we do nerve testing? As I mentioned, we're looking at the function of the nerve, and this is the median nerve here, sensory. This is the radial nerve sensory and ulnar nerve sensory. And like I previously mentioned, we can't just rule in or rule out carpal tunnel just by looking at the median nerve. We have to make sure other nerves are also involved in the test and make sure they're functioning fine in order for us to say, okay, it's isolated to the carpal tunnel nerve, which is the median nerve. So this patient, we do the test, and we'll see that the peak latency is 4.0, which is delayed, where it should be coming in before 3.6. For this patient who is 46-year-old female, fairly healthy, she should be coming in somewhere around 3.0, 3.1. So 4.0 is pretty delayed. The size of the nerve is pretty maintained at 31. It's greater than 10. So it's fairly good size, but delayed. Looking at the radial nerve, 2.1 milliseconds, and a size of 20, and the ulnar nerve, 3.0 milliseconds, and a size of 38. Those two nerves are look pretty fine. So this is pointing towards a carpal tunnel, being that it's isolated to the carpal tunnel nerve. But we're not done yet. Next, we're going to look at the motor component of the nerve, as the nerves have a sensory component and a motor component. So in the motor component, we'll again do the median nerve and the ulnar nerve, which go through the wrist. And we'll see that, again, the median motor is coming in at 4.3. And for somebody her age, she should be coming in somewhere around 3.3, maybe 3.4. But 4.3 is delayed. Again, she's maintained the size pretty well. And looking at the ulnar motor, latency comes in normal at 3.0, size is at 8.7 and it's normal. And again, we're showing that the other nerve going through the wrist is normal. So this is again really pinpointing it towards just the median nerve going through the wrist, and we're pretty much ready to say carpal tunnel, except not quite yet. There's one more thing we need to do, and that's the electromyography part of it, the EMG. And the reason we have to do the EMG is because we do need to make sure that we're not dealing with anything else that could be giving them pain or numbness in the wrist or hand. And a pinched nerve, for example, at a C6 would give you numbness at your thumb or your index finger. And in order for us to say this is absolutely, definitely a carpal tunnel, we also would need to rule that out, which is why we would do the EMG. And for this person, the EMG was completely normal. There was no funny abnormal activities, normal insertional activity, normal motor unit activity. And so now we're not seeing any pinched nerve activity. The ulnar nerve, the radial nerve were fine. It was the median sensory and the median motor that were delayed through the wrist. We can comfortably call this a carpal tunnel. And it does seem somewhat involved, but you really have to do everything that I'm mentioning, because otherwise there are situations where you might miss out on some other reason that might be causing the pain or the numbness. So in this case, we would call this a moderate carpal tunnel syndrome or moderate median neuropathy across the wrist. We would say it's affecting both the sensory and the motor components, because the sensory was delayed and the motor component was delayed. And we would call it primarily demyelinating. And by demyelinating, we're saying that the axon is fairly maintained and it's just delayed as far as its speed goes. And this is what you might typically see on a report. And we'll kind of talk about this terminology at the end too. Maybe I can answer some questions in regards to what it specifically means for you. Case 2, 56-year-old right-handed male, mechanic for 20 years, has had mild occasional back pain here and there over the years, but he develops an acute left-sided low back pain radiating down the left lower extremity after lifting a radiator. He's had persistent pain, 7 out of 10 pain, associated numbness in the left foot. He feels some subjective weakness. Medical history significant for hypertension. He's had physical therapy, which has given him some help. He had a couple of epidural injections and provided him pretty good relief, but wasn't really lasting more than 1 to 2 weeks. And this is fairly typical cases we'll get also. And this is basically a typical lumbar radiculopathy case that we'll see. So what do we see in a case like this? Well, again, we're going to start off with our nerve conduction study. First, we'll look at the nerve conduction sensory. The typical sensory nerves we look in the leg are the sural nerves. Sometimes we'll look at saphenous or the superficial peroneal, depending if there's a particular reason. But generally speaking, standard sensory testing in the legs are the surals. And this patient has perfectly good speed and perfectly good size, so the sensory looks fine. We're not finding a reason for the numbness in the feet. Then we look at the nerve conduction studies, the motor components, the peroneal nerve and the tibial. And for the most part, it's pretty normal as well. The peroneal nerve on the left comes in at a good speed, has a normal size. On the right, good speed, normal size. The tibial nerve on the left, good speed, normal size, and on the right, good speed, normal size. So we're not really finding a good reason for his pain and numbness from the nerve conduction study, but we're actually showing that there isn't something in the lower extremity that's causing the pain. For example, a impingement at the peroneal head or a tarsal tunnel or something like that. So we're basically ruling out peripheral nerve injuries in the leg by doing the nerve conduction part of the test. So now we're going to move on to the electromyography, the EMG component of it. And this is where we're looking for the electrical signal abnormalities based on a pinched nerve axonal injury. And what do we see on the right side? Pretty normal. On the left side, we're getting increased insertional activity in anterior tibialis, extensor hallucis longus, the posterior tibialis. We're getting 1+ fibrillations. in the extensor hallucis longus, and we're getting 2+ positive sharp waves and 1+ positive sharp waves in the posterior tibial. Now this is pointing towards some kind of an axonal injury. So now we can say that there is some kind of an axonal injury, and we can say that it's in the L5 distribution, but we're not quite done yet. We're almost ready to call it a L5 radiculopathy, but the only way I can really truly call it an L5 radiculopathy is to go into the lumbar paraspinal muscles. These are the muscles in the back, and look for abnormal electrical activity in the back. If I don't find electrical activity in the back, I can still say that it's most likely a lumbar radiculopathy, just statistically speaking, and because finding abnormal electrical activity in the back is sometimes difficult because getting the muscles to relax in the back is difficult. So I can say it's most likely, statistically speaking. But the only way I can really truly rule in a lumbar radiculopathy is to find abnormal electrical activity, like we found here, 2+ in the lumbar paraspinals. Now I can confidently say there's a connection with the lumbar muscles in the back, which are provided by the L5 root, to this muscle and to these muscles down here. And the nerve testing part that we saw beforehand didn't show any particular abnormalities in the peripheral leg, so now I can confidently say this was an L5 radiculopathy. But again, you need to do both parts, the nerve test, conduction test, and the electromyography to rule out any peripheral injuries in the leg and to rule in abnormal electrical activity in the muscles of the L5 and in the back. So we would call this an active left L5 radiculopathy. Who performs electrodiagnostic tests? For the most part, it's physiatrists, physical medicine and rehab, like myself, neurologists as well. And sometimes there's technicians that would be doing the nerve testing in assistance with the examiners. Technicians, generally speaking, will do, they must be formally trained. Now they'll do the nerve conduction study only. The EMG is done by the practitioner. Although I believe now nurse practitioners can also be qualified to do the EMG component as well. So when is an electrodiagnostic test appropriate? And I think this pertains to you guys because I'm sure you get a lot of referrals and requests for the nerve testings, and sometimes it can be overwhelming as far as, well, does the patient really need it? Is it appropriate? And I can say that there's no absolute rule. There are a few ACOM guidelines, which basically says a persistent radicular pain from the spine. And by persistent, usually we're talking about 6 weeks or so, and having performed conservative treatment such as physical therapy. Sometimes equivocal imaging, such as disc bulges. You get a patient, they'll get an MRI, and there's a disc bulge at C4-5, there's a disc bulge at C5-6. Well, studies have shown that you can have patients with absolutely no pain whatsoever in the same age group as the patients we see, a 50-year-old gentleman, and they have absolutely no pain, but they have multi-level disc bulges. So does this disc bulge really mean anything? Is it for this patient something that's significant? Well, a lot of times we just don't know, and so doing electrodiagnostics can sometimes help in finding a radiculopathy and saying, you know what, in this particular patient, this C4-5 disc bulge is causing a C5 radiculopathy, so it's significant for this patient. Other times, as per ACOM's guidelines, is suspicion of other neurological conditions, and that's what I pertained to earlier when I mentioned, for example, you want to do a shoulder surgery, but you want to make sure there isn't some other neurological conditions such as a C5 nerve pinching that's mimicking a shoulder pain. Outside of ACOM, these are some other things that generally we see in practice that I think are important reasons to do nerve testing. They talked about, ACOM talked about persistent radicular pain. Well, persistent numbness is also a reason. For example, in carpal tunnel, you're not necessarily going to get pain all the time, but you'll get persistent numbness. And by persistent, again, we're talking, generally speaking, 6 weeks, having done conservative treatment, wore the wrist braces, you did some physical therapy, and you still have persistent numbness. That's an appropriate reason to do nerve testing. Persistent pain in the extremities. Outside of the spine, you can have all kinds of nerve entrapments, such as the tarsal tunnel or a cubital tunnel, which will give you all kinds of persistent pains, for example, at the elbow or the ankle, which conservative therapy has not helped. That would be an appropriate reason. Again, not within the first week of them coming in with an elbow pain, but once they've had a fairly good amount of conservative treatment and they still have the persistent pain at the elbow, all right, you know, it would be reasonable to look for a radial nerve or an ulnar nerve entrapment. Unclear diagnoses, I think that basically is self-explanatory. If the patient's been being treated for 3 months for vague symptoms, they're not getting better, nobody really knows exactly what's going on, nerve testings can shed some light. Confirm a diagnosis of entrapment neuropathy. That I just put in there. This is a must, which is basically what I was saying. Carpal tunnel is not carpal tunnel until it's truly shown to be a carpal tunnel by the nerve test. Because there's a lot of things, overuse syndromes that will mimic carpal tunnel, but it's really just tendinitis. And you don't want to be performing surgery on a tendinitis when the nerve is fully intact. So I feel a very strong component towards making sure you do nerve testing to rule in a carpal tunnel or a cubital tunnel before you do any kind of a surgery, to make sure that nerve actually is affected and it's not just an overuse syndrome, tendinitis, that's mimicking a carpal tunnel. And other reasons would be impairment ratings. I know QMEs and AMEs will see patients, they've been treated for 5-10 years, and now they want to give them some kind of impairment rating. Well, they'll send a patient to us for nerve testing to see, well, all right, you know, is there actual nerve injury? Or if they had surgery, is there residual nerve injury and whatnot? So it helps them with impairment ratings. And the last thing that I put is muscle atrophy. Muscle atrophy cannot be ignored. If there's muscle wasting, I wouldn't even wait 6 weeks or wait for conservative treatment. If you're getting muscle wasting, nerve testing should be done to figure out why is there wasting of the muscle, because that is a kind of a red flag for something serious going on. EMG and nerve conduction studies together, and the basic answer to that question is yes. For the reasons that I spoke about earlier, is they complement each other. When I want to rule in a carpal tunnel, I would need to do the EMG to make sure that the numbness is not coming from a C6 pinched nerve. And vice versa, when I'm ruling in a C6 pinched nerve, with the EMG, I really need to rule out some kind of a nerve entrapment like a carpal tunnel at the wrist that's giving them pain and numbness in the wrist or thumb. So they really complement each other, and you really need to do a full test to make sure that you're ruling out other stuff and to equivocally rule in a specific diagnosis. And finally, before we go to questions, this is the final slide, is terminology used in the final impression. And I imagine you guys come along a lot of these reports you get, and you wonder, what do they mean with this impression where they say it's mild or it's moderate or it's severe? They'll say it's chronic, or they'll say it's acute or active, or they'll say it's demyelinating or it's axonal. They'll say sensory, it's motor, and sometimes you might wonder, well, what am I supposed to do with all this stuff? That's a good question. I would say that for the most part, when I say sensory or motor or sensory and motor, and when I say demyelinating or axonal or demyelinating and axonal, I'm really talking to the referring provider, the referring surgeon. I'm not sure if this really would be too significant for case managers or adjusters, because basically what I'm telling the surgeon is, how significantly is the nerve affected? Is it affecting just the sensory, or is it affecting the sensory and the motor, which would make it more significant? And is it just affecting the speed, or is there axonal loss, which tells the surgeon, okay, there's more significant nerve injury going on? And I think it's more technical talk for us, and I'm not sure if it'll make necessarily much difference for the case managers or the adjusters or whatnot. Although you can certainly look at it, and based on our talk, kind of make some assumptions based on things that are being said. I think case managers and adjusters can pay a little bit more attention to acute versus chronic, and mild, moderate, and severe, because these would pertain to what exactly is, as a whole, general picture going on with the nerve. Is it something that's, and I don't like the word acute, I prefer the word active, because acute, generally speaking, means it happened now. But a patient can have pain for 2 years and still have what we call acute radiculopathy, which it's not really acute, it's been going on for 2 years. It's more of an active radiculopathy. So I'm pushing for more of this terminology, and more people are using active as opposed to acute. But generally speaking, when you guys see acute or active, you can deduct that it's an ongoing injury. It's something it's still happening. The patient, the nerve is still being pinched. It's still, the axonal injury is going on. It's still an active issue. If you see chronic radiculopathy, they'll say it's a left chronic L4 radiculopathy. They're basically saying there was some kind of a nerve injury, disc herniated, it pinched the nerve, but it's not an ongoing pinch. It's not an ongoing axonal injury. The injury happened, there's no more compression on the nerve, and we're seeing chronic changes on the nerve because there was a point when there was an axonal injury that occurred, but we're not seeing any more active. We're seeing old changes from the injury that occurred, let's say, a year ago or 2 years ago. And so if you see chronic and non-active or acute, I think that can help you guys deduct a injury as far as how current is it and how active is it. And if it's chronic, does something need for it to be done now? Well, sometimes if it's a chronic injury and not active or acute, maybe you don't have to do something too invasive for it right now. And so that's something you guys can pay attention to. When we talk about mild, moderate, and severe, this becomes much more difficult. Difficult in the sense that there isn't necessarily an absolute consensus of what's mild, what's moderate, what's severe. And also, patients' symptoms don't necessarily correlate with mild, moderate, and severe. For example, we can get a patient with a mild carpal tunnel, slight little sensory median nerve that's a little delayed, but they have a lot of pain and numbness. And then I've seen patients with a severe-looking carpal tunnel, and they don't have much symptoms. It was a kind of an incidental finding. They were here, they came for a pinched nerve rule out, but we found a severe carpal tunnel, but they didn't really have much symptoms in the hand or wrist. So it doesn't necessarily correlate. When we say mild, moderate, severe, we're not talking about the symptoms. We're really talking about what's going on with this nerve. The nerve is mildly damaged or affected, moderately affected, or severely affected. Now, I would say that in the nerve conduction studies, although I said there isn't a consensus, most of us would call a sensory nerve that's affected and is just delayed and it's maintained its nerve size, we would call that mild. We would call it moderate when the size of the sensory nerve is also affected, or the sensory is delayed and the motor is delayed, but they both maintain size. We would call that moderate. And then we call it severe when the sensory and the motor are both affected, that they're both delayed, and there's loss of nerve size. Then we'll call that severe. And that generally seems to be an accepted consensus with the severe. When it comes to the radiculopathies, the pinched nerves, I don't like mild, moderate, or severe at all. I basically say chronic L5 radic or active L5 radic, but I never use the word mild, moderate, or severe. Well, I shouldn't say never. There is one time that I would use the mild, but that gets a little bit more complicated in regards to H waves and H reflex abnormalities and whatnot. But for all practical purposes, other than that, I would never call mild, moderate, or severe. And I think most practitioners don't or should not, because if you see electrical signal abnormalities on the EMG, it's by definition going to be at least moderate or severe, because there has to be a notable compression of the nerve for there to be electrical signal abnormalities. So it's just by definition, it's going to be moderate or severe. But we can't really differentiate between moderate and severe based on the waves we see, because there is no consensus as far as the amount of the electrical instability that we see or the size of it that would differentiate between a moderate or severe. We can assume, but we really have no good studies that would differentiate between the two. And so generally speaking, when it comes to radiculopathies, the pinched nerves, we should never say mild, moderate, or severe. We should just say a C5 radic, an L5 radic. So if you see a radiculopathy that's not chronic, it's active, it's significant. It's at least moderate, if not severe, because you're not going to see electrical instability unless it's a good nerve compression with axonal injury. And if it says mild, I would really question it, or it would really be just that one exceptional case of an S1. They could say a mild S1 radiculopathy strictly based on abnormal H waves and a normal EMG. So if they say it's mild S1 based on an H wave, that would make sense. Otherwise, it doesn't make much sense. It's going to be at least moderate to severe. You're going to have a notable compression. I don't know if that helps or not. That's basically the gist of it. Questions? Yes?
Can you describe how you differentiate between diabetic neuropathy and compression on the nerve? Can you repeat the question?
Yes, the question was how I would differentiate between a diabetic neuropathy versus a compression and entrapment neuropathy. And that basically goes back to this slide here. Let me get this back to a slide show. Slideshow. Oh, here we go. Is that the show now? Go to the bottom here. This one? To the right. Here. This one? Ah, thank you. To answer that question, we'll go to our case one here. In a diabetic neuropathy, you're basically not just going to see this one nerve here that's delayed, which pinpoints it to the median nerve being entrapped. You're going to see a delay here, you're going to see a delay here, you're going to see a delay here, you might see some loss in size, but it becomes what we call a peripheral polyneuropathy, meaning that we can't localize it to one single nerve. It's a global delay in all these nerves we're seeing. And that's when it becomes a diabetic peripheral polyneuropathy. And that's why we need to do all the nerves before we can call it a carpal tunnel, because we need to show that all the other nerves are normal. So an entrapment neuropathy would be, this is the only nerve that's delayed going across the wrist, the median nerve, and all the other nerves are normal. And we can say it's going across the wrist, all the other nerves are normal, that's carpal tunnel, versus all the nerves are delayed. It's a global delay. And then we'll basically then characterize it as a sensory peripheral polyneuropathy, a sensory and motor peripheral polyneuropathy, demyelinating and axonal, but depending on what we find. But the diabetic neuropathy is a more global finding of the nerves as opposed to the isolated nerve across the wrist and everything else being normal. Yes?
Is there medical necessity for doing left versus the right extremities?
That's a good question. The question was, is there a medical necessity to doing the left versus the right, bilateral studies versus unilateral studies? If you ask us, the practitioners, we say yes, because we always like to compare. It just sheds a huge light for us when we see different speeds, different sizes, and we want to compare it to the other side to say, okay, for this particular patient, this is the normal size and speed. Is it absolutely 100% necessary? No. When I get a patient like this that is so clear-cut carpal tunnel, it's just everything is pointing to carpal tunnel. The EMG looks fine. The motor component looks fine, other than across the wrist, and the sensory looks fine other than across the wrist. No, I would be very comfortable with this. There are times where it's not so textbook. It's a little bit iffy, shady. It kind of looks like a carpal tunnel. Maybe the ulnar is kind of borderline, but the median is much more delayed, and I wanted to call it the carpal tunnel, but I want to know if the ulnar on the other side is also somewhat delayed, and maybe that's just normal for the patient, and so I'd like to do the other side. But what I do is, even if the patient is strictly referred for one side, and they're authorized only for the one side, for the quality of the test, because my job ultimately is to give my best impression, I'll explain to the patient that, listen, they've referred you only for the right, but for me to give a complete impression of what I think, I really want to test your ulnar sensory on your left to see if that's kind of your baseline on the left side as well, for me to make a better judgment. And patients pretty much always agree and they understand. And I'll do a limited study on the left side on the nerves that I think would help me make a judgment on the right side, and I'll just do it. So it's not absolutely necessary, especially when it's so textbook, but it certainly helps, and we like to have the option of being able to do it when we need to. And patients are always okay with it when you explain it to them why you're doing it, and it's just a limited nerve that'll help you. So yes, it does help. It's not absolutely necessary if it's clear-cut, but it certainly does help in some of the iffy studies. Questions? Questions? Yes?
What happens if you do both tests and then the result is a possible radiculopathy?
A possible radiculopathy. I don't know why you would get a report as a possible radiculopathy. You get that? You get possible radiculopathy as a it says possible radiculopathy? Let me see what it says. Okay, possible left S1 radiculopathy. This might be the H wave issue I was talking about. This is a non-specific repetitive and large motor units are seen in the Yeah. The person really should have said chronic, because they're talking about enlarged motor units, and those are the chronic changes that I was talking about. So really, they should have differentiated between the chronic and the active. They should have said chronic neuropathic changes in the left S1 distribution of non-specific significance is really what they should have said, because it's pretty misleading to say a possible left S1 based on just having some enlarged motor units in that one muscle. It should be chronic neuropathic changes in the S1 distribution of non-specific significance. Really. They're really stretching to say possible. Yeah. Yeah.
Well, but along that line, why is there not standardization in the reporting amongst the practitioners?
That's a good question. I think it's because it's quite a complicated test. And because the symptoms don't necessarily correlate with mild, moderate, severe, and because we don't have good studies, especially with the EMGs, in regards to +1 or +2 fibs, +1 versus +2 positive sharp waves, and do those mean mild versus moderate versus severe? We don't have any studies to differentiate the two. So I think there is poor consensus because it doesn't correlate and we don't have good studies, especially with the EMGs. But I think the practitioner can really help you guys out by being more specific, not necessarily using the words mild, moderate, or severe, but just saying, there's some chronic neuropathic changes in that muscle and it's fairly nonspecific and there's no particular significance to it just by itself. If they word it out like that, I think it would just make much more sense to explain to you guys what they're saying, and then not use the words mild, moderate, severe, especially with the EMGs. Was there a question? What's that? Oh, yes. Yes, it does, and generally speaking, we try to correct for that. So, for example, the patient that we saw, or the example that I gave, oh man, I did it again. Go right there, and then go. This one here. This mild median nerve sensory that's just a little bit delayed. It just moved a little bit from the left to the right, just a little bit. If this was an 85-year-old patient, I would not call it a mild sensory carpal tunnel. I would just say that's part of the norm for her age group, unless again, we never just do the median, we'll do the ulnar, we'll do the radial, because we want to compare. Unless the ulnars and the radials are coming in at really good speeds, and this is still fairly delayed compared to the other ones, then I can say even for her age group, because the other nerves are coming in so fast, that this is still significant. But when I see that this is coming at 3.9 and the ulnars at a 3.8, and the radial is coming in at like a 2.7, and they're all somewhat delayed, it's normal for her age group, and I wouldn't call it anything of significance. So yes, we do adjust for that. Yes?
So then, if the testing was done by an applicant-oriented facility, is there a chance that it could read as positive when really it could be within normal limits?
Well, ideally, I would like to say there's no chance. Generally speaking, we're not doing tests on too many 85-year-olds. Most of our patient populations, at least in the workers' comp setting, are in their 30s and 40s and 50s. And there isn't that much of an adjustment you'll do in that age group. And ideally, you want to practice, good medicine. And I would say applicant or not applicant, you want to call it as it is. So I would say hopefully not. Yes?
Is there anything that we should look for as we're evaluating these reports that have come from applicant-oriented sources, if you will, that would help us have some comfort level as to whether we're looking at an accurate or tester, or if we're looking at someone that's skewing it? Are there any red flags to look for?
Well, I don't know what kind of stuff they're trying to pull off. So I mean, I wouldn't be able to tell you. I mean, I just call it as it is. I would say the more specific they are, the better the report. And so when you get a report like this lady had that was a possible S1 redic, those are stuff I think that are red flags. Is basically they just want to rule in something or call something. It just doesn't. That doesn't make much sense. I think the more specific they are, the more meaningful it is. If they're saying sensory demyelinating median neuropathy across the wrist, they're being very specific. It means they really have reasons to call it what it is, and they have the numbers to show it, as opposed to just saying carpal tunnel, and they're not saying, is it sensory, is it motor, is it demyelinating, is it axonal? So I think the more specific it is, the better it is. The more explanatory it is, the better it is. And I'm not talking about sometimes they give you like a paragraph of disclaimers. I'm not talking about that stuff. I'm talking about specific as to the diagnosis. I would bank more on that.